Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, I'd like to give a big thank you to Dr. Emily Godfrey for coming today. Dr. Godfrey is going to talk about contraceptive issues with antiretrovirals, a topic that comes up periodically, and we've had a request from our participants to talk more about. Dr. Godfrey is associate professor here and an expert on contraceptive issues, and I will turn it over to her.
Great, thank you, Brian. So Brian had asked me to talk about the contraceptive antiretroviral drug interactions and issues to consider when prescribing contraceptive to HIV-positive patients. And just a little bit about myself, I am a relatively new faculty member here at the University of Washington. I came from the CDC, the Centers for Disease Control and Prevention. And what I was doing when I was there, I was actually working on national guidelines that we now have available as it relates to women with underlying medical conditions. In addition, they also talk about some characteristics. So the antiretroviral medications are actually on the list, and we'll go through that a little bit today. I'm still contracted with the CDC, and I continue to work on guidelines for the CDC. So just briefly, I'll go over the epidemiology of HIV in the United States, talk about the available contraceptive methods here in the United States. I'm never quite sure where my audience is at in terms of how well they know what's available, because there are new methods that are kind of coming to the market. The latest one was back in February, so I just want to make sure we're all aware of all the different methods that are available. Pharmacokinetics of hormonal contraception and antiretrovirals, which probably you know better than I do. And then the reason why I bolded the last bullet point, evidence-based national contraceptive guidelines, is that's really where I'll kind of slow down, and then we can talk about that a little more at length, and I'll take questions at the end. So very briefly, epidemiology of HIV in the United States, and I'm focusing on the United States because I'm assuming that if you are prescribing, we're prescribing to patients here in the US and not abroad. So we know that in terms of the latest data that we have, 2010, 1 in 4 people living with a diagnosis of HIV infection here in the US are women. And in 2010, women accounted for 20% of the estimated 47,000 new HIV infections. And most of the new infections were from heterosexual contact with a person known to have or be at high risk of infection. And women aged 25 to 44 years accounted for the majority of new HIV infections, which is why contraception is so important. These are women of reproductive age. And so the role that contraception has when it comes to HIV-infected women is truly the prevention of unplanned or mistimed pregnancies, because we know that if we get a woman on treatment before she's pregnant, we have optimized her health, and in addition, we decrease the maternal-to-child transmission. So a little bit about the contraceptive methods that we have here in the United States. I'm going to start with what we call long-acting reversible contraceptive methods, or for short, LARC. And there's 3 types. Well, I should say there are 2 types. There's 1 implant and 2 different types of IUDs. So the implant is a progestin-only contraceptive implant. It works by inhibiting the hypothalamic pituitary ovarian axis and also by cervical mucus thickening. Progestin also causes a uniform uterine atrophy. So basically what it does is it sheds the uterine lining. It's been FDA approved for 3 years, and its side effect is the unpredictable bleeding. We also have 2 separate kinds of progestin-only IUDs, and they actually don't primarily work in terms of having adequate serum levels of progestin. So there's only a partial inhibition of the hypothalamic pituitary axis. It does primarily work by cervical mucus thickening and also uterine atrophy. The 1 type of progestin-only IUD that it's been on the market now for a good 12 or 13 years. The brand name is called Mirena. It's FDA approved for 5 years, but it's been shown to be effective for up to 7 years. There's a smaller IUD that was released in February of 2013 called Skyla, and that has been FDA approved for 3 years. Then the last type of IUD is a copper IUD, so it's a non-hormonal IUD. And how it works is mostly through a sterile inflammatory response in the uterus, and enhances prostaglandin production, inhibits various endometrial enzymes such that it inhibits the kind of mechanism of capacitation for sperm. So in fact, sperm never meet egg. So it's contrary to a lot of sort of theories that people have that somehow the egg is fertilized and the egg doesn't implant, or the blastocyst doesn't implant on the uterine wall. And in fact, it doesn't work that way. It works by mostly inhibiting sperm meeting egg. That has been FDA approved for 10 years, although it's been shown to be effective through 12 years. And the downside of this method is that some women will complain of some cramping or bleeding during their periods. And then, of course, the injectable contraceptive methods, which we know are very, very popular, certainly in sub-Saharan Africa. The depomedroxyprogesterone acetate, or DMPA, it's also a progestin only that inhibits the hypothalamic pituitary ovarian axis. It causes mucus thickening as well as uterine atrophy. And that is an injection that's given every 3 months. And then the combined hormonal contraceptive methods. So what do we mean by combined? So we're talking about methods that have both estrogen and progestin. So we know about the daily pills, and there's also a weekly patch. So a woman places a patch on somewhere on her skin, and it lasts for 1 week, and she does that for 3 consecutive weeks, and then the 4th week she has no patch. And then there's also a monthly vaginal ring. So that goes in, and it stays, goes into the vagina. It stays in the vagina for 3 consecutive weeks, and then she pulls it out the 4th week and has a withdrawal bleed. So again, these methods work by inhibiting the hypothalamic pituitary axis. Progestin in particular suppresses the LH surge, and estrogen suppresses the FSH surge. And it's really the progestin that makes these methods effective. It's the estrogen kind of causes some more stabilization to the uterine lining, so there's less breakthrough bleeding with these methods, but in general, we really depend on the progestin in terms of efficacy. And of course, we know about side effects. The patch in particular can cause some discoloration where the patch has been. And the vaginal ring, it's important to counsel your patients and let them know that usually after a month or 2 of use, she will have some increased vaginal discharge, which is fine if she's kind of on the dry side, but some see it as a disadvantage and don't want the method for that reason. The CDC has basically adapted this chart, which was been kind of around at the WHO, and in the United States, we decided to sort of break it down to 3 separate tiers in terms of effectiveness. So you can see in tier 1, we're talking about very effective methods, sterilization, both female and male, and we know that sterilization is permanent and not reversible. But we also have the implant and the IUDs. And so the point being is that an implant and an IUD are reversible, but in terms of effectiveness, it's just as effective as sterilization. The tier 2 has the very popular methods, the injectable, the DMPA, the contraceptive pill, the patch, the ring. And then tier 3, you can see also very popular, the male condoms, as well as female condoms withdrawal and periodic abstinence. So when we talk about pharmacokinetics of hormonal contraception and antiretrovirals, what we're really concerned about is how effective our methods are. We worry about the interaction will cause a decreased effectiveness in the method a woman's using. So just briefly, in terms of the pharmacokinetics of an ethinylestradiol plus progestin method, if it's an oral method, she swallows it, it's absorbed from the small intestine, which then heads to the liver, and it gets metabolized through the first pass effect, which we know is the cytochrome P50 mechanism. And so if you look on the right, you look at the boxes on the right of the screen, you can see that ethinylestradiol activates a CYP3A4, which is just a type of enzyme in the cytochrome P450 mechanism. And so it increases the rate at which drugs are cleared by the liver from the bloodstream. Less is known about progestins, but there is some theory that the progestins also somehow affect the first pass effect. And if you look at the box below on the right side of the screen, you can see that we worry about enzyme-inducing drugs decreasing circulating ethinylestradiol and progestins and potentially reducing the effect of the oral contraceptive. And in fact, and I'm speaking very broadly here, and again, this is probably something you know far more about than I do, but in terms of the drugs we're looking at, so on a broad level, when we talk about the non-nucleoside reverse transcriptase inhibitors, or the NNRTIs, we can see that for the most part, they induce the cytochrome P450 system. They're inducers. So that's where we would worry, just going back to the bottom box on the right, we would worry that if patients taking an RTI, that the oral contraceptive pill is going to be less effective. But if we look at boosted protease inhibitors, we can see that, in fact, it's a cytochrome P450 inhibitor. So if it's inhibiting this cytochrome P450 system, then we worry that, in fact, there's an increased serum levels of ethinylestradiol and progestin. So that's in theory. And then you can see that the NRTIs, the nucleoside reverse transcriptase inhibitors, for the most part, don't have an effect, as well as the integrase inhibitors don't have effect on the cytochrome P450 system. As I was looking through your website, and I think this is actually a phenomenal website, I see that a lot of the research that has been done looking at drug-drug interactions is summarized very nicely on the website. So I took this from one of the HIV drug-drug cases, if you're wondering where I got it from. And so without going into detail about every different antiretroviral, we can see, though, that in summary, the ritonavir boosted protease inhibitors, so in reality, so in theory, we worry about drug dosages, the ethinylestradiol drug dosage being high, but in theory, but in reality, what's really happening is that it actually decreases the ethinylestradiol, even though it's an inducer, or sorry, an inhibitor of the cytochrome P450. So this is why it's always so important that we do clinical studies rather than try to assess, well, what's happening in theory, because many times what we see clinically is not what happens in theory. So for this reason, because the ethinylestradiol dosage, as well as most of the progestins, are decreased with a protease inhibitor, an alternative method or backup method is recommended. And we know that the non-nucleoside reverse transcriptase inhibitors are, in fact, inducers. So we expect the ethinylestradiol levels to go down, as well as the progestins. And for the most part, you know, it happens certainly with the Sestiva, and so alternate method is recommended. And then it looks like the nevirapine also causes reduced levels. So, you know, I suppose if you really want to get into the science of contraceptive pills and antiretrovirals and really keep track of which one your patient's on, you could follow this. But for me, I would say, you know, this is pretty complex, and I like to keep things broadly. That's essentially what these evidence-based national guidelines do, is they help keep kind of the picture broad, so you don't have to think too hard when you're in clinic with patients. So these guidelines are called the U.S. Medical Eligibility Criteria for Contraceptive Use. They were released in 2010, and it was released as an MMWR, which means that every time guidelines are released as an MMWR by the CDC, it will be updated. So it's going to be updated again probably 2015. It covers more than 60 characteristics and medical conditions. And basically what you'll see for every medical condition, there will be the different types of contraceptive methods, and you're going to see a number between 1 and 4. And a 1 is essentially a green light, that there's no restriction for the use of the contraceptive method for a woman with that medical condition. A 2 is a little bit less of a green light, but still a green light. The advantages of the method generally outweigh the theoretical or proven risks. A 3, I would think of it as a yellow light, but yellow doesn't project well, so we've given it pink. But the theoretical or proven risks of the method usually outweigh the advantages. So consider another method if there are a 1 or 2 available. And a 4 is a definite red light, that there's good evidence to suggest that there's unacceptable health risk if the contraceptive method is used by a woman with that medical condition. The other thing about the MMWR is that there's a laundry list of various medical conditions, and you can see that HIV/AIDS is on that list. And essentially what this list is saying is that women who have these medical conditions, their condition will worsen if they become pregnant, which is why we want to make sure that HIV is well controlled prior to pregnancy. And we know that if she gets no treatment at all during the pregnancy, her HIV will worsen. And for that reason, the CDC is saying that you, as a provider, should consider long-acting, highly effective contraceptive methods for these patients. So we really need to be thinking about tier 1 contraceptive methods for these patients until their medical condition's under control and they desire pregnancy and understand the risks involved in being pregnant. So what does the medical eligibility criteria say about drug interactions, in particular the antiretroviral therapy? And you can see, if we look at kind of just the first 4 methods starting from the left, so we're looking at combined pill. P/R means patch ring. progestin-only pill, injection, implant. We can see that certainly for the nucleoside reverse transcriptase inhibitors and even the NNRTIs are either a 1 or a 2. Basically, it's a green light. But we can see for the ritonavir boosted protease inhibitors, it's given a 3, and it's specifically referring to the pills, 3. And we know that from the evidence that we already reviewed that's on your website. Now, the IUDs are a little different, and you can see right below the method, the levonorgestrel IUD and copper IUD, you see an I and a C, and at the bottom of the slide, I means initiation, C means continuation. So you may be asking yourself, well, why is it a 2/3? And so to understand why it's a 2/3, we have to go to this medical eligibility criteria entitled HIV. So there's a condition under HIV. And what they did was they separated out to high-risk women. So generally, I don't know, discordant women who are, they themselves don't have an infection, but they may be having intercourse with a man who does have HIV infection. And then HIV-infected, AIDS, and then clinically well on therapy. And so again, you can see for the actual diagnosis of HIV that most methods are a 1. It's a green light. And really, it's only when you get down to those who actually meet clinical criteria for AIDS, you can see that the levonorgestrel IUD and the copper IUD under I, so initiating, is a 3. And so the theory behind the recommendation of a 3 was if somebody's meeting clinical definition of AIDS and you place an IUD, you may actually induce or introduce an infection and as a consequence of introducing an IUD into the uterus. And so the advice is to get the AIDS sort of under control so that the woman then meets the definition of clinically well on therapy or HIV infected, and then the risk is reduced to a 2. So that's why in this slide it's a 2/3. So generally most patients we see in this country, they're not meeting the definition of AIDS and they're HIV infected, and so in that case it would be a 2. But if your patient's meeting the definition of AIDS, then it would be a 3 to introduce an IUD. In terms of what continuation means, what it means is if you have a patient who shows up on your doorstep and she's already has an IUD in place and she's either HIV infected or meets the definition for AIDS, your question is, well, do I need to remove the IUD because she might be at increased risk of infection with a foreign body in the uterus? And the answer is no. So the continuation is a 2, which again, it's not a full out green light, but it is a softer green light. And so in general, as a clinician, you can feel pretty safe keeping your patient on that method until she is clinically well on therapy. In terms of where to find the guidance, I recommend just typing in CDC contraception and you'll get to the website. And in terms of what they have on the website, so they have the MMWR. But this is a summary chart, and I did bring some here. So a chart both in English and Spanish. There is an app on your phone that you can do if you have an iPhone. Unfortunately, they don't have anything for Android or for Palm, but that you can also download from the website or go to the App Store on the iPhone. And then there's also a pocket-sized wheel, so it's meant to be like a contraceptive wheel and fit in your white coat pocket when you're seeing patients. To let you know that there's a new set of contraceptive guidelines that were released in June of 2013. And the purpose of these guidelines, they're called the Selected Practice Recommendations for Contraceptive Use. It's really to help you as a clinician in terms of how to use the contraceptive method. So once you've deemed, like, for example, a levonorgestrel IUD is safe for your patient, but she comes back to you 3 or 4 months later saying, I'm having all this breakthrough bleeding in between periods, this is the document you go to in terms of best evidence for treatment of things that come up when a patient's already on a contraceptive method.